Good afternoon. Thank you very much, Dr. Brandt. So now I have to defend the open thyroidectomy. The standard thyroidectomy implies an incision in the neck, and it has been the standard of care and the best practice for many years. Several techniques have been developed with two main aims. One, to reduce the size of the incision, and second, to place the incision outside of the neck. If we analyze the pros and cons of these procedures, we can see that the main aim of most of the procedures is to improve cosmetical results, but this is to the expense of compromising exposure. Cosmesis is not the main outcome in any thyroidectomy, whereas exposure in surgery is as important as it is location in real estate and safety in airlines companies. Dr. Chang presented a beautiful review of the robotic thyroidectomy, and I would like to do a comparative analysis with the standard technique using some methodology. The ideal way to assess a new procedure is first to identify the outcomes, then to gather evidence, then to do the analysis and to interpret evidence, and finally, to implement the change. Main outcomes for thyroidectomy are divided in three different areas. In order to assess the cure rate, it is important to know survival, but also disease-free survival. We know that main complications in thyroidectomy are recurrent laryngeal nerve palsy, hypoparathyroidism, and bleeding. And in the box of others is surgical time, hospital stay, return to work, cost, pain, and cosmetic results. I will be presenting you three comparative studies. The first is a comparative study of 25 patients undergoing either standard or robotic thyroidectomy. You will see that general characteristics of the two groups were very similar. Operative time was consistently higher in the robotic arm. Most patients had benign disease, and in addition to the operative time, was also a significantly higher blood loss in the group of patients who underwent robotic thyroidectomy. This is a different study comparing 30 patients undergoing conventional thyroidectomy against 16 patients undergoing robotic thyroidectomy. We can see again that general characteristics are very similar. Different to the previous study is that most patients in this study had malignant disease represented mainly by papillary thyroid carcinoma. Complications in both groups were very similar. However, when they looked to the operative site discomfort 2 weeks after surgery, the study showed that it was greater after robotic than after conventional thyroidectomy. Now, let's see what is the cost of removing the scar away from the neck. In this study, Dr. Jennifer Cabot did an analysis of 3 different procedures: standard thyroidectomy, transaxillary endoscopic thyroidectomy, and robotic transaxillary thyroidectomy, 30 patients in each group. We can see that there were 2 differences found. The differences were that the operative time was more prolonged in the transaxillary approaches when compared to the standard approach. And the second difference was in cost. Transaxillary endoscopic approach was more expensive than the conventional thyroidectomy, and the robotic approach was the most expensive of the 3 different procedures. This data or these comparisons were established using data from the Yonsei Hospital in South Korea and also the Wade Cornell Medical College in New York. The pathological analysis in both groups was very similar. What we also found in the cost is that both the endoscopic and the robotic approaches had an increase in cost as the surgical time also increased, and that the number of cases per year didn't have any impact on the endoscopic and the standard approach, but in order to reduce the price of the robotic thyroidectomy, they needed more than 100 cases per year. In a different study, where the operative time of the robotic approach was less than the standard approach, the authors found that despite the fact that the surgical time was less, the costs were as high as 2 times the cost of the standard thyroidectomy. As I showed at the beginning of my presentation, there have been another surgical techniques used in order to improve cosmesis, and one is the minimally invasive video-assisted thyroidectomy. A systematic review of the available data showed that this is feasible, practical, and it's a safe alternative with better cosmetic results. This systematic review went to a deep analysis, and the deep analysis also provides highly favorable comments on the minimally invasive thyroidectomy. Comparative studies between minimally invasive thyroidectomy and gasless transaxillary thyroidectomy have been performed, and these comparative analyses have shown that the operative time is less when the minimally invasive approach is used, and also that the hospital stay is less, and the pain score in both the day of the operation and the day after the operation is also less with the minimally invasive approach. The number of injuries to the laryngeal, to the recurrent laryngeal nerve was also smaller in the minimally invasive approach, and also the number of overall surgical complications was smaller in this group. When they analyzed the appearance of the scar, there were no differences in scar appearance between both groups. So if we summarize the main comparisons, operative time, pain score, recurrent laryngeal nerve injury, and overall morbidity, all these comparisons favored minimally invasive thyroidectomy. Last year, it was published a meta-analysis analyzing the papers that compare robotic versus endoscopic approach. From initial number of 111 papers, 6 papers were analyzed. None of them was a randomized controlled trial. They did include benign and malignant diseases. And the meta-analysis showed that operative time was very similar between both techniques. The number of conversions was also very similar. There was a higher number of complications in the robotic technique, also a higher amount of liquid coming out from the drain. The hospital stay was very similar, and the number of lymph nodes harvested was also very similar. At the beginning of this year, a comprehensive review of recent advances in the surgical treatment of differentiated thyroid carcinoma was published. And when they analyzed the different surgical techniques, they found that the robotic-assisted technique required a longer learning curve and didn't show any advantage when compared to the other techniques. It is important to remember that laparoscopic surgery has shown significant advantages in many surgical procedures, such as the one shown in the screen. However, in thyroidectomy, the only potential benefit that this technique may have is in cosmetic results. We need to realize that to move the scar away from the neck not necessarily means that we are improving the appearance or the quality of the scar. We may end up by hiding in the axilla an ugly scar that would have been better if it had been placed in the neck. If we are so interested in improving cosmesis, I would like to emphasize some few surgical details that may help, such as to mark the incision, to do it in skin wrinkles, to protect the incision, to excite the traumatized skin, and to use non-absorbable monofilament for the muscles and also absorbable for the skin. The current evidence has shown that robotic thyroidectomy requires a longer operative time, a more prolonged learning curve, has a higher frequency of complications, and has a higher cost. Therefore, Dr. Chung, ladies and gentlemen, I am happy to tell you that open thyroidectomy is and will continue to be the preferred approach. Thank you.